Hello and welcome to Bristol Health Cares. I'm your host, Kurt Barwis. I am the president and CEO of Bristol Health. This program is for you. It's really about how you navigate the system of care, how you access care, and it's really about trying to answer questions you may have and really didn't know who to ask. We are going to bring to you professionals, doctors, surgeons, other healthcare professionals throughout our system of care, maybe people that you've never talked to before or met before, but the goal is to really help you understand how to access care when you need it. You're going to enjoy this program. This program is really for you. So what's important is if there is something that you want to learn about or know about or a guest that you'd like me to host on this show, write us and we'll try to make that happen for you. So enjoy the program, Bristol Health Cares. Welcome to Bristol Health Cares. I'm your host, Kurt Barwis. Today, I have a very special guest, Dr. Andrew Lim. Dr. Andrew Lim, tell us about yourself.
Well, first off, thank you for having me.
It's awesome.
I've been at Bristol Health for coming up on 10 years, which is amazing.
10 years?
Yeah.
Wow, I didn't realize you had been there that long.
Yeah, it's been 10 years. My background is emergency medicine. I'm a Connecticut guy. I grew up in Fairfield County, but went to UConn for med school. When I finished my residency training in Florida, I did a look around this area, and thankfully, there are a lot of choices in this area. But I'm happy with my decision to come to Bristol.
Yeah. So you came into Bristol in the ER group at the time, right? And
correct,
was it MEP, I guess?
MEP initially, yeah.
Yeah. And so when you made that choice, you obviously had other choices. Mm-hmm. What attracted you to that group in particular?
Yeah, so one of the toughest things to gain during an interview day is culture. And with a little bit of experience under my belt, I knew that I wanted to be in a place where I could build a career. And for me, what was most important was I wanted to love the people that I work with. I wanted to come to work looking forward to practice medicine with a team that would support me. And that's definitely held true at Bristol. The fact that we're a community hospital, I love our team, I love the people I work with, and that was true 10 years ago, and I was able to get that sense when I came for the interview, and honestly, that's what's kept me here as well.
Yeah. We were going through a change, right? So you came in with the new ER group, right?
Yep.
So you navigated kind of a transition, and you were part of that initial group that came in, which was amazing. And for me personally, I've been at the hospital for 16 years, and the focus on emergency medicine was very important. Obviously it's really important to the community and the board, and you were part of a group that just turned around, the way the community felt about the ER. And I know that because I saw the satisfaction scores went from, not so good to any given month, the top in the state of Connecticut in terms of how patients rated us and things like that. And so that, to me, that whole group that came in was just an incredible change for the community. And I guess I hadn't really thought that, I didn't realize that you were part of that initial group, but that makes a lot of sense to me now. You worked in an environment that was pretty old, huh?
It was. I share an anecdotal story that when I was being recruited, my boss at the time had told me over the phone, at least, we have a great team. You're going to love the people you work with, but when you enter the building, just close your eyes and don't look at the walls, right? So I share that story. I shared that story multiple times when we, as we went through the renovation.
Yeah.
That it makes me proud that we finally have a building that fits the high quality care that we provide.
Yeah, again, the feedback from people in the community when they come through the door now and they see it, it's just incredible. And and you were a part of helping design that environment, that very unique environment. So let's go back a little further. So what made you want to be a doctor? How did that happen?
Yeah, no, that's a great question. I mean, I think at the heart of it for almost every physician is that willingness to, or that desire to heal, to help people. Interestingly enough, I never, in my medical school training or residency, I never saw myself as a physician leader, or I didn't see myself going into administration. But I think that the light bulb went off when I realized that, as a physician, you feel fulfilled by helping the people that you meet on shift, right? Whether that's 20 people, 30 people in a shift, you get to touch the lives of those people. When you're able to be at the table to help make bigger decisions to affect more patient lives, you can help that many more people. It can be 100, it can be 1,000. You get to touch the lives of many more people. And having a physician background, I'd like to think that I do have a little bit of intel or knowledge to know what can work and what our patients are looking for.
Yeah, it's really kind of, you're touching on something that's like central to why I believe that I chose to be in this environment. While I don't heal anybody, I get to feel good about the people that we take care of and all the feedback we get. I feel like I'm a part of it, and if you extend that to the entire organization, there's not a person in the organization that can't find that same feeling, right? Yeah. So you picked medicine, and then what now? And you kind of got a little ahead of me too, because you're talking about administration. But what made you go for emergency medicine? What about emergency medicine was like the thing for you? Because you could have been an OBGYN, you could have been a general surgeon, you could have been a primary care physician. Yeah,
I think what excites me about I think the opportunity in emergency medicine is really helping people in their darkest moment, right?
Yeah.
So my mantra has always been, every patient that comes into our emergency room is essentially having likely the worst day of their lives, right? And so I have this running joke with a lot of patients that I meet in the ER who, perhaps I have taken care of them for a second time, a third time, and usually I'd like to think they're happy to see me, and they say something to the effect of, well, it's nice to see you, Dr. Lim, but not in the ER, right? So we kind of joke and kind of get that, it's not a great day because, by default they're in the emergency room. But my point being is that, in those, I get to take care of people in their sickest states and their most critical states, and I feel fulfilled when, we can make them better, and in the emergency room, that means making someone feel better over the course of a few minutes, maybe a few hours, but we get to see that we get that immediate feedback as well too. And I'd like to think that I've been able to convey that to our ER team, is that we can provide a little bit of comfort, and that doesn't mean picking the right antibiotics or making the right decision to get a certain test. What that means is not being above bringing someone a warm blanket, bringing someone a drink. And and that's really the culture that I speak of, is that it's not the job of a tech, it's not the job of a nurse, it's kind of all of our jobs that we can aim to not only provide the right care and quality care, but also make our patients feel cared for is the difference.
It's kind of interesting that and so as a non-clinical person, I kind of rationalize in my mind, like so your world is, you use all of this knowledge and skill that you have to very quickly assess what's going on with a patient. You then have to stabilize the patient and then make decisions about what's going to happen to that patient. Can they go home? Do they need to be admitted? Do they have to go to a skilled facility for rehab or something like that? But there's this intensive, short duration kind of okay, I'm going to use everything I have in my mind. I'm going to figure this out. I'm going to make this right, and I'm going to get some tests or whatever to help me with my decision process. But your whole kind of approach is not approach, but your whole like environment is intensive, and then when you leave your shift, what happens? What do you do?
Well, I try to decompress. That's number one, is to, I try to take care of myself. But, honestly, when what that brings to mind is, what am I thinking of on my way home? And I think of, there's usually a couple cases. My wife knows me well and, always wants to hear, about what we call a good save, or a good catch. And, and that's what fills my bucket, or the people that I've helped that day, whether it be making a good diagnosis or making a diagnosis that I think might have been difficult. Or, honestly, it could just have been helping someone through a tough time.
Yeah.
So those are the things that kind of stick with me and the things that I kind of bring home.
It's interesting when I think about like emergency medicine, general surgery, you get individuals like yourself who go through this intensive period of time and then they're finished. They also tend to be the best scoffers in the world because they finish, they go and they shift and then they go back and do it again.
Yep.
And kind of going back to what you talked about, the leadership piece of it, leadership is difficult in that you don't get that gratification. Mm-hmm. Like you solve a problem, you take somebody and you get them in the right pathway, you get them to where they need to be, and you feel good about that. And in my world, that could take years, right?
Yeah.
Like think about the ER itself. At 16 years, we've been talking about replacing the ER. 16 years later, we finally did it, and it's that kind of a thing. And so it's very curious to me that you really are embracing this other pathway that you're traveling down, which is leadership, which it's sometimes it's like sailing. You could see like in medicine, you could see what you got to do and you get it done. But in the administrative or leadership world, sometimes you got to tack 24 ways to get to the point you want to be at the end. And so you really have an interesting kind of mindset to have both of those things. And I think that's really an awesome quality of yours.
Thank you.
It really is. So you talked a lot about the culture of the organization, the culture of the group that you joined, and I know this morning there was a study. I'm not going to ask you questions about it, but Hopkins published a report. It actually appeared in the Hartford Courant today, and it talked about the mistakes made in the ER environment. Mm-hmm. And I forget what the time frame was, but Hopkins did the study for CMS, but I think a lot of the data came from overseas. But they talked about 200,000 misdiagnoses.
I did see that. Yeah.
You saw it, right? And it's mind-boggling when you think about, you don't know that patient when they walk through the door. Mm-hmm. You really don't know them, and you don't necessarily have their history, although we're getting a lot better as an industry in that you can now look through the electronic record, and if it's a patient of another hospital within Connecticut, you can pull in data if you want to.
Correct, yep.
And so you can start to see what's going on, and sometimes patients can't talk to you, mm-hmm. And you're dealing with a proxy or a friend or something like that. What's really kind of interesting to me is that your group now is a national group. USOCS is a national group, and they've actually studied and developed specific protocols for certain disease states. So maybe you could talk a little bit about that.
Absolutely, yeah.
Blew me away the other day when I heard that, and then
Yeah.
to see the results across the nation, mm-hmm. startling to me.
No, that's a very good point. So I think the for me, what that means is, I think as technology advances, there's this myth, there's this healthcare myth that more is better, right? So if the doctor orders me a CAT scan, that's great. We're going to get to the bottom of this. If he or she orders me an MRI, fantastic. I've had the Cadillac of all tests. And the reason that's a myth is because in medicine, I feel that there's been a push to order more tests to either prove or disprove a diagnosis. But in reality, the money is in sitting with the patient. That's really the bread and butter, is getting a good history, listening to the patient, and coming up with what we describe as a shared decision-making model, right? So it's a paradigm shift from, maybe 20, 30 years ago when doctor walks in, you have this, this, and this, you need to do this, this, and this, end of story. So we like to, our emergency medicine group likes to practice in a shared decision model. So what does that mean? So let's say someone comes in for chest pain. Naturally, we think of all of the life-threatening things that could be causing chest pain. You think about heart attacks. You think about blood clots in the lung, known as pulmonary embolism. You think about problems with the aorta, which is the major blood vessel. So how do we tease through that? Do we need to order a CAT scan on every single patient that comes in for chest pain? And the answer is no. And the reason that's harmful is that CT scans, although they're useful in evaluating these disease states, with time, the more CAT scans you have, the higher risk of radiation, And I think for the ER provider in front of that patient, that doesn't necessarily mean that they're going to develop cancer the next day and blame it on the ER doctor, but it's a downside for 20 years, 30 years down the line, and we want to do the right thing. So how do we give the information or the tools to our ER team to say, hey, this person doesn't need a CAT scan, this person would benefit from a CAT scan, is that clinical management tool that you're alluding to. And so what we use is evidence-based medicine. So we look at studies that have evaluated millions upon millions of patients to say, hey, if a patient has a fast heart rate, if they have a low oxygen level, then yes, a CAT scan would be a benefit. But if these clinical criteria are not present, the chance of the patient having a blood clot is so low that it's actually better to not get the CAT scan. So we arm or give the tools to our clinicians to make sound decisions, and which truly in the end benefit the patient, because that's really what it's all about. So it's kind of using technology, using evidence-based medicine to make the right decisions for the patient in front of us. And sometimes it takes a little bit more time, right? So, what I always tell my patients is that it's actually easier for me to order every test at my disposal. Yeah. Is it the right thing to do? No. It takes more time to explain the why, to explain why we're doing certain things. But at the end of the day, every single time I've done that, patients appreciate it because they like being treated like a person. They like being treated like someone who can make a rational decision, right?
Yeah. It's interesting, I think about, my career, and I think back about this person that I knew really, really well, and had very complex cancer, and had tumor removed from the brain, and then went through a period in which they had really severe nausea, vomiting, instability, and literally spent weeks in 2 different health systems, weeks, tests, procedures, everything, like nonstop. And it kind of gets back to something you said about where you get the value of spending your time, is at the bedside, is with the patient, talking to the patient. And after, there could be they couldn't figure out what was going on, that person ended up getting a consult with Dr. Zacco, our gastroenterologist. I think he's like our Dr. House. And he did an intensive H&P, just talk to me about what happened, when did this start, how did it lead up? And it turned out in 20 minutes from that conversation that he identified that she had, in a break, taken a vacation in between treatments for the cancer, gone to Mexico, and contracted a very unique virus in her stomach, and within minutes was able to, prescribe medicine that had an impact almost like within a couple days. And this was going on for months. But, so for a non-clinical person, it kind of, really brings home that bedside conversation, the value of the history and physical, the in-depth, because there could be so much more going on. And
Absolutely.
all the tests in the world. I mean, this poor person was poked and prodded and not tests that were easy, they were invasive tests, right? And in the end, none of it was, was really necessary. It was really a sit-down, in-depth conversation that resulted in a better outcome for that patient. So
exactly.
I don't know, to me that kind of reinforces, in my mind, what you just said. Probably you talk about a much more complicated environment where, people present with, as you said, chest pain or something like that. But I think the thing that really brought it home to me, going back to those protocols that you have in place, was seeing the results. So you're not just saying, we're going to implement this. You're looking at it and actually tracking the outcomes, and you're, in many respects, improving the application of those protocols.
Absolutely, yeah. So as a national company, we have a lot of data, both nationally and locally, and we know for a fact that because we've made it mandatory for our physicians and providers to review those protocols, use those protocols, go through education, we've been able to track and actually see a difference in regards to bad outcomes, both locally and nationally, to say, hey, on this date we started these clinical management tools, and we've seen a gradual decline of bad outcomes, which is at the bottom line is, which is great for our patients,
Yeah, and Bristol Health, that ER and that team, I mean, you guys have done and delivered extraordinary care there. And
thank you.
In terms of outcomes, it's unbelievable what you've been able to accomplish. So let's talk for a minute about, the last couple of years, and something else that's kind of unique about you that I find very, very special. So you were on the front line of the pandemic, and you were very often the person that the network TV stations and newspapers talked to, mostly a lot because you were willing and you just kept stepping up. But you did this incredible job of educating the public. And you did something else which was kind of unique. You came to us and talked about using telemedicine, which, everybody started using telemedicine. But the idea of doing ER telemedicine, this, could we do emergency medicine differently? So talk to me a little bit about that. Because, I just was blown away by it.
No, thank you. What I would say is that the idea for ER telemedicine really was one of those 3 a.m. moments when, during the first weeks in March, when the state had shut down, people had stopped seeking healthcare, people were basically sheltered in place. And what I realized was that, when ER volumes dropped, let's say, for instance, we were used to seeing about 110 patients per day, we were seeing probably about 20 to 30 a day. But I noticed that although the patients stopped coming, the phone calls had increased, right? So I would be sitting on shift, and our charge nurse would answer the phone and try to give medical advice, and would conclude the call by saying, you know what, legally I can't really tell you what to do. I can't provide medical advice. We're here if you need us. And that's when the light bulb went off, was to say, hey, there's, we're seeing about 20 people per day. There's probably about 90 people in our community that need help. They need evaluation. Maybe they don't necessarily need to be here in person, but hey, let's be creative and create a system where they can reach us, where we can actually provide structured medical advice and care. And so I'd say, almost, it was pretty amazing how this came together. Within a month, we were able to go live and kind of open up the phone lines and create a structure where we could formally have people call one number, have patients call one number, and actually speak to, over FaceTime, an ER physician. And I believe we're one of the first, definitely in Connecticut and also in the country. I'd say, initially it was a pretty good success, but I think it evolved. As COVID evolved and as we gained new therapies, the benefit of having that built-out service was amazing, right? So, as we started to, as a hospital, receive novel treatments like the monoclonal antibodies, we had to figure out a way to be able to evaluate patients appropriately, but then also administer the treatments, right? And so we knew that, part of it was not simply patients calling up and scheduling an appointment for treatment. There are certain criteria. We knew they had to be within a certain amount of days. They had to have certain medical history. So there was a lot that went into the evaluation. Telehealth was perfect for that. So I believe we had one of the most robust programs in terms of monoclonal antibody use. And as a small community hospital, that's something I think we're all very proud of, right?
Yeah, for me, I know a lot of people in the community. I live in Bristol, and people would call me up and say, "Hey, Kurt, And they don't think they realize completely that I'm not a clinical person, but they'll ask me questions like, what do you think? Am I a candidate for this? Da, da, da. And what that did for me personally was I have like a standardized text now. Listen, call this number, schedule an appointment with an ER doc. They're going to go through the screening, and they're going to answer your questions. And it worked incredibly well. I had an individual in Florida who was worried about what they should do, and I sent it to them. So you've actually, think about this. Bristol, Connecticut did ER visits in Florida, and I think we even did one overseas at one point because of the travel going back and forth between all the travel restrictions. So and the volume, so if somebody has a concern, they're not sure whether they should come in or not, they can use the visit, they can call up and actually talk to an ER doc.
Exactly.
Right? And then you help them make that decision. And if they're coming in, you're prepared for them, right?
Yep.
Really works out well. But very innovative. And in healthcare, the laws, the rules, and regulations they're not at all like other businesses. There's a tremendous amount of restrictions and hesitation and compliance issues. And so innovation like that, comes with a whole bunch of legal considerations. And and for the layperson, you'd sit there and say, well, how can that be? Well, it is because there's also, as you read, there's also abuse that happens, so that there's protections built in, and I say this all the time. What makes sense in business never makes sense in healthcare when it comes to business, right? It's a different world, and the persistence with which you went after this. I can't remember how many meetings we had. We had multiple meetings, and we were trying to process the legality of doing it, and ultimately we figured it out. And I know that the parent company, USEX, does it in other places now very successfully. So it has become what I think is something that's going to be here to stay for a long time.
Hopefully,
right?
Yeah.
Because not everything's when you're not sure, it gives you that added sense of, I made the call, I checked, I talked to a doctor, and maybe it's not something I'm 100% sure about. So how does somebody access that? They just call the main number of the hospital?
Yeah, so they can call the main number. We do have a dedicated telehealth number. I don't know it off the top of my head. I should. No, I failed.
That's okay. We'll get it for you.
Yeah.
But I think the most important thing is for the community to know that it's there, it's available, and it's an awesome resource.
Yeah.
And it could be, remember, there's an ER doc in the ER at all times, 24/7, 365. So when you call in the middle of the night or you have an issue in the middle of the night, you're going to get a doctor, right?
Exactly.
And so that's a really, really cool thing.
Yeah, and the thing I would add is that that program is a perfect example of how being small and being a community hospital can allow us to pivot. right? So
Yeah.
during all of COVID, I think as an organization, we were able to change direction on a dime, right? And we could see that, compared to our other hospitals in the area, that we
Yeah.
were able to implement things like telehealth, monoclonal antibody treatments, prescribing Paxlovid over telehealth. We were able to change direction and provide new services so much more quickly
Yeah.
than some of our other colleagues.
We were the first to set up the testing facility.
You're right.
It would have been within hours. We were the second, but I'm pretty sure we were the first in the state to
Yeah.
do that. And to get all the approvals necessary to do it through the Department of Public Health. So it's, I agree with you. I feel, for me personally, having worked in larger systems, and I'm just one of these people that, and I grew up in a community hospital. I started as a patient transport, and so you kind of understand the culture, and you understand how things work. And I'm just not a very patient person. So if I went to medicine, I probably would have been an ER doc, because I need that constant thing. But the reason I stay in this environment, and I've stayed, it's just because of what you said. It's, you can create and sustain an incredible culture, and you get stuff done. There's no politics, right? It's just like, we make decisions, the medical staff, the administration, the hospital, and then we execute them, right? Very efficient, very effective. And it's really kind of a cool environment to be in.
It is.
So now you were the medical director, the director of the ER for some time, and then you kind of got the bug for leadership. So you started to talk a little bit about that, but how did that happen? Like,
Yeah. Yeah, so I think there was a natural extension to the hospice side. In regards to hospice medicine, I became the medical director for the inpatient units. And I would say there's a natural extension because part of that handoff process from the ER is that when patients go upstairs, they get taken care of by our hospice team, a team of physicians and APRNs to continue that care. So in my book, it was kind of a continuum of the care we're providing in the emergency room. As I have started to grow as a leader and as a clinician, I started to realize that, part of the beauty of the Bristol Health Medical Group is that we are multi-specialty, right? So how do we start to leverage that multi-specialty nature to create those cross connections, so that our primary care docs are working with our orthopedics, who are also working with our surgeons and our oncologists. How do we make those points? So how do we make those connections so that for our patients, that transition is seamless, right? To have everything in one system, and work effectively, where the communication is quick and where we can pick up the phone. That's the beauty of the size of us, is that we have the size to have a great system of many specialists, but we're small enough where, if you're sitting in the oncologist's office and you need to see the urologist, they can pick up the phone, right? It's a cell phone call, and they'll pick up, and we can set up procedures quickly. We can set up imaging quickly. We are working on initiatives like direct scheduling, right? So if you go to your primary care doctor and perhaps you twisted your ankle and you need to see the orthopedist, before you leave, you'll leave with an appointment to see the orthopedist, and who, by the way, is down the hall or on the next floor in our medical care center. So just the proximity of services, just the collegiality of the medical group, I think really lends itself to great care. And so that's what excites me. As I started to grow, you asked me about my growth as a leader, and it's funny. 10 years ago, I came in, as a staff ER doc, but as I started to grow personally and professionally and started to know the organization, I've started to get more excited and realize the true potential of the group.
Yeah, it's really interesting. You stepped off of the fact that you were running the ER, and then you took on the hospitalist, you know. So, and I've been in this thing long enough to have lived through the transition between community-based primary care docs coming to the hospital to take care of their patients, and people not feeling like, I don't know this person, and now that's what you have. You don't really have community docs coming into the hospital anymore. But there's some interesting dynamics in a hospital. So, you know, the idea of an emergency room doc overseeing inpatient medicine, you know, it's like they're two different worlds. You know, as we talked a little bit about, you know, your job in the ER is to, you know, assess, understand, diagnose, stabilize, and move the patient on. And now all of a sudden you're overseeing where they're moving them on to, right? So I think it was kind of really interesting when we started to kind of work through that process, because I think we all felt you were the right person. But there was a reaction to that, right? There was a reaction to, wait, how can you have an ER doc overseeing this part of it? That doesn't feel right. But it's, you know, from my sense, it's working incredibly well, you know? And there's a tremendous amount of respect that has evolved as a consequence. And it's, and I think the other thing is there's a logical kind of connection of what's going on here to what's going on there. And we are a system of, you know, if you step back and look at the hospital, it's plumbing in a lot of respects, right? So if the ER is getting backed up and you've got patients that need to be admitted, you need to be able to get them up to the floors, right? And the floors have to be ready to accept them. So when you have someone that kind of bridges the two and can see what's going on up here, are they ready? Are they capable? Is it better for the patient down here? As opposed to having, you know, the ER team saying, you need to come down and get this patient now. You need to come down and get this patient now. Having that bridge, I think, creates a much more informed and appropriate, you know, transition. And does that make sense?
Yeah.
I mean, it just feels like that's what we lived through in the beginning, and I don't hear anything about that anymore, which is so cool.
Yeah, I think you kind of hit on a lot of the challenges for healthcare across the nation, right? We all know about the staffing crises with nursing. I feel that thankfully we're in better shape than other local hospitals. But you're right. I mean, in terms of patient flow through the hospital, front door to the back door, you know, the ER is the front door. But you know, having to be able to have oversight onto both processes, I think makes sense.
Yeah.
You know, and I think at the end of the day, the patients benefit, right? If you can get your treatment, move through more efficiently. You know, although we have a brand new ER, you know, it's not great to stay for days in the ER without a bed upstairs. So we realize that throughput, you know, throughput on the hospitalist side also affects throughput on the ED side too, right? So for our patients who don't need to be admitted, we want to get them seen. We don't want patients sitting in the emergency room, waiting room for 2 hours. You know, we kind of joked when we were building our new ER. You know, why even build a waiting room? We don't keep people in the waiting room.
Yeah,
right?
I do remember February and March when, you know, COVID was surging of 20, and there was 100 people, and we only had half the new ER done.
Yeah.
So it was really was quite extraordinary. So I'm glad we did actually build the waiting room.
Yeah.
There were still people outside at that point in time.
Yep.
But you know, it's kind of like I guess what people from the outside don't necessarily kind of readily recognize is that, you know, within a system of care, and you see this a lot, like suppose you have a, you know, very complex patient that needs ICU level of care, and, you know, the ICU has only one bed available, and they're full out and maxed. So they're here and you're here. And I think what people don't, you know, often see or realize is that there is a tug of, you know, why can't they take the patient upstairs that goes back and forth. And that, as long as I've been doing this, that's always been the case. You know, ICU, ER, med surg, ER, and, you know, the flow of patients but I don't feel that here, which I think is the advantage, is that, you know, the kind of the system of care, the size, and, you know, it's not that it doesn't percolate up every once in a while. Of course it will, because there's always going to be very complex patients where, you know, the floor nurses are going to say, I really need to just focus here, and we listen to that, and then we have to hold somebody downstairs. There's other unique features of this emergency room that are kind of very special, like our behavioral health unit. You know, talk to me about, you know, as we get through this staffing crunch, we've also created an observation unit in the ER. You know, how's this going to play out for us in terms of changing the way we do care?
No, that's a good question. I mean, the behavioral health unit was actually in the first phase. You know, I give you a lot of credit, Kurt, for recognizing that community need, that there was a need to have a dedicated behavioral health unit within the emergency room. It's a beautiful unit. You know, I think, as you know, during the building process, we had toured other facilities in the state, and I think the general theme for behavioral health units in the emergency room was that it was gray, you know, it was a locked unit. It was not conducive to therapy. And frankly, it felt a little, most that we had seemed kind of like a jail, right? Our behavioral health unit it's warm, it's inviting, it's safe, there's visibility. And I think all of that adds up to providing a more therapeutic environment for our patients who are frankly having the worst day of their lives, right? So I think the fact that we chose to build that in phase one, I think speaks volumes about our response to, you know, what we determined was a huge need. You had mentioned the ED observation unit. Having a bigger ER has allowed us to keep observation patients in the emergency room. I think for most people, for most patients, you know, the differentiation between inpatient and observation is not something that most lay people recognize, right? So what does that mean? So for some patients who, you know, we'll come back to chest pain. So for some patients who have chest pain, and we've done our evaluation in the emergency room, and we determined that, you know, they might need a little bit more. Maybe they need a stress test to take a closer look at their heart, but it's 9 o'clock at night, and you know, we don't have stress tests available, but it's first thing in the morning. And, you know, we should probably continue checking blood work throughout the night. That's kind of the classic observation patient to say, hey, you have a symptom that's concerning. At this point, the tests are negative, but we know that we need to go a little bit extra mile just to ensure that, you know, you're not having a heart attack. We can keep you in observation status, keep you in the emergency room in the bed that you've already been in, arrange for the stress test in the morning with the plan that if the stress test is negative, you can go home. So what does that mean? What's the benefit to our population? Well, that means that you're not going to be in the hospital a minute longer than you need to be, right? And not only does it benefit you, but it benefits your neighbor who's out in a waiting room trying to get in, right? So it's kind of multifactorial, but you know what it speaks to is that, you know, we're willing to commit resources where we think there's going to be benefit, you know, and the ER team likewise stepped up to come up with the protocols, the education, to train the team. The nurses have been fantastic, you know, despite all the staffing crises that, you know, we've gone through. The nursing staff has been willing to step up and say, yes, we'll take on this additional initiative to make it work. Yeah.
So, and it's the other thing about this that I think is really amazing is to take a patient from the ER and admit them into the med-surg unit or ICU or somewhere else. That's a whole process, and I think people don't understand. So your orders in the ER are completely stopped when the patient gets admitted, and then the admitting physician, the hospitalist in this case, has to create all new orders, and now a whole process goes into play. So there's assessments, there's dietary restrictions, there's food, all this other stuff that happens on a med-surg unit or in an ICU that doesn't happen the same way in the ER, right? And so when that patient, if that patient doesn't go to observation in the ER and they get up into the hospital itself, all these processes that are designed for inpatients kind of take over. It's not necessarily a bad thing in some respects, but there's a lot of administrative stuff that happens. And so patients that could be, as you just described, a patient that could be gone in 24 hours or less, 18 hours, 20 hours, we're gonna watch this patient overnight, we're gonna do a simple test in the morning, and we're gonna then discharge them. If they go upstairs, it's a whole different world.
Exactly.
Right? It's a completely different world. So when you look at the data around this, you have patients that are observation in the mainstream of the floor, right? So if you're a nurse on the floor, you've got an assignment of so many patients, and you manage your workflow and your patients the same way. You're indifferent to this one's an observation, this one's an inpatient, right? Mm-hmm. And so the amount of time that a patient stays in observation in a main floor can be more than 2 days sometimes. Mm-hmm. But when you do it in an environment where your mind is, I'm going to assess, I'm going to manage, I'm going to stabilize, and I'm going to figure out where to send them off to. It's like a whole different mindset. The time frame, to your earlier point, they're out of the hospital faster. It also impacts the cost of care, and There's a lot of focus on the cost of care and affordability in this state of Connecticut. So, well, anyway, so now just going to play forward a little bit. You are now the medical director of our multi-specialty group, right?
I am. Yep.
That's your new role. So how do you tell me about that role? How do you feel about that?
I thank you for the opportunity, but it's a great role, and the reason I've been in this role for 4 months now, and I feel I say 4 months, but I feel like I've been in the role for a year with how much has gone on, right? So, I think it was a big decision for me to take a step a little bit away from clinical medicine. I still enjoy clinical medicine and still work in the ER at least once a week. But for me, I think the opportunity was to play a bigger role in terms of improving the system. Not that the system was necessarily broken, but seeing how we can improve our medical group, for our patients. What kind of exciting new projects, what kind of exciting new initiatives can we create to improve access to care, right? To streamline our processes so that, patients aren't frustrated with trying to set up appointments, so they're not getting lost, so that there's, appropriate communication between our specialists as well too, because that's should come natural, right? I overheard a little bit about during your last interview about the kind of shared governance too, and that's frankly one of the beautiful aspects of our provider groups, right? Is that culture, is that ability to hold each other accountable. Right. So if we have a provider who's struggling in some aspect, whether it be with the patient experience, whether it be with access to care and making sure that we're getting patients in a timely fashion, we can utilize our strengths as a group, to come in and either hold people accountable or bring that physician up.
Yeah, it's really the coolest thing for me as an administrator, right? Being a non-clinical person in a clinical world, and and over the years, I'd have people say to me, "Well, just tell them they got to do it." And I'm like, "You don't understand. So that's not how it works." So the medical staff reports to the board of directors separately than me. They don't report to me, and they shouldn't report to me because I'm not a doctor. Mm-hmm. And so, going through that evolution of independent practice to now dominantly employed practice, I liked independent practice medicine. I loved it. And so the medical group is an employed model, yet it emulates the private practice of medicine. It's to your point about how you have like-minded individuals, you have clinical people governing the group, which, and there's a rotation. So it's not like, I say this to physicians when we're going through the recruitment process. To join our organization isn't just to be a doctor here. It's going to require you to play a role. So you might serve on a finance committee for the group, you may serve on the board of directors, you may serve on the clinical quality committee, but you can't come here and not be a part of this governance process. And it's a selfish thing for me because, you know, in the old days you had physicians would socialize, go play golf together, social clubs, whatever, and through that they bonded, and I think that's where a lot of the clinical excellence came from, because they worked with each other, they talked to each other. So I see this structure as bringing together, you know, the physicians. So if you're going to sit on a committee together, maybe you don't know this person who's referring you patients, right? Maybe they're not in the medical center, maybe they're out in the community, but you're going to get to know them. You're more apt to pick up that phone and talk to them. And the excellence is just incredible. So
absolutely, yeah. Yeah, I mean, what I would say is, you know, I've been, you know, a lot of the discussions around the table are about how, you know, how do we make things better for our patients, right? So I was, as an example, you know, our cardiology team had actually come up to me a few months ago to say, hey, you know what, we want to make it easier for our ER patients to follow up with us, right? So the patient that comes into the ER for chest pain, we want to give you the ability to set them up with an appointment when they leave the emergency room to come see me, right? Which is a complete, which is, you know, if you've worked in other hospital systems, you know, is completely contrary to what is probably happening in other hospitals, right? Yeah. So, you know, and what that tells me is that there's a lot of trust, right? They know that we're going to pick the appropriate patients. Yeah. That they're opening their schedule and allowing us to fit patients where they need to go. And that doesn't happen without trust. That doesn't happen without an engaged medical staff who wants to do the right thing, right? And that's that culture that I speak of, is that our culture is, at the end of the day, if you just do the right thing for the patient in front of you, no one can fault you. Right. And that's what brings us together.
Question. When you say trust, I mean, I can imagine the public is trying to figure out, wait, I don't understand. So what happens in a practice like a cardiologist, you know, the last thing you want to do is do a 4-hour block of time where none of the patients really needed to see a cardiologist. So that's the trust you're talking about. Exactly. That somebody's making that decision and it's an appropriate decision. So, you know, so they are seeing patients that they should be seeing. So, so it's really exciting to hear, you know, you talk about, you're not just talking about the medicine part of it, you're talking about the other part that matters so much is, how do I navigate the system? You know, how do I navigate a complex system? And all too often I'll get a question from somebody like, you know, I don't know where to go, I don't know what to do, I don't know how to do it. And, you know, and I think the ultimate goal in my mind is, you just call that number and we'll help you figure that out for you. We'll navigate you to the right place. And that's, you know, that's kind of what I see in the multi-specialty group. And as I was making that point about the governing body, nobody stays in a position forever. There's term limits, which means that as the physicians who don't necessarily get training on governance and all these other things, as they evolve through this and maybe they take a turn on this committee or that committee, they ultimately get to a place where they have a total picture of the organization and they really do feel like they belong. So, so where do you see yourself ultimately going, Dr. Lynn?
Well, ultimately, I'd love to be sitting in your chair giving the interview, but
hey, you know what? I would be really excited for you to do that, and I absolutely think you've got the talent too. So
yeah. No, but honestly, I'm extraordinarily happy where I am. You know, 10 years ago when I moved here, I wanted to find a place that, you know, I use the word specifically, I would use the word career, right? Because it's not a job. I knew I wanted to be invested in where I was. I knew I wanted to kind of fill that bucket, you know, and feel fulfilled at the end of the day with what I do and who I'm treating. And, you know, I plan on continuing to grow with Bristol Health, however, whatever that means or whatever that looks like. And so, you know, my long-term plan is to, you know, keep growing with the organization, honestly, wherever that takes me, you know. And as I start to kind of get my feet set in this role, you know, I'm just glad for the opportunity and learning every day. So
we're just thrilled to have you as a part of this organization, a part of our leadership team. There's no question. So folks, this was Bristol Health Cares.